A very good evening to us all and a very happy new year. I welcome everyone here present to the very first edition of the Young Nigerian Neurosurgeons Forum monthly webinar of 2025. In the previous couple of years, in very exciting sessions that we've had, education, sharing of experience from our YNNF members who are residents in neurosurgery in various institutions all over the country, and gotten some very brilliant and experienced oversight from our senior faculty who are always coming to share, make very important. And today, no different. I've actually been looking forward to this edition, and glad that our senior faculty have introduced new course. But without wasting time, I wish to welcome everyone to this session, and I want to hand over right away to our moderator for the day, who is the person of Dr. Elsie Campbell, a consultant neurosurgeon practicing Delta State University Hospital. So you're welcome, Dr. Campbell. You can take it from here.
Yeah, good evening, my chairman. Can you hear me?
Yes, we can hear you.
Yes, yeah. Thank you so much. This is an important webinar by the Young Nigerian Neurosurgeons Forum, and usually done. This particular webinar will be hosted in Sokoto by Osman Danfodio University Teaching Hospital, Sokoto, where we'll have resident doctors that will present this important topic in neurosurgery. The topic for today is surgery for common CNS anomalies. And we are looking at relevant embryology anatomy of common CNS anomalies. That's the first topic. I will be presented by Dr. Aliu Landan from Osman Danfodio University Teaching Hospital, Sokoto. And the second topic, the operative steps of management, myelomeningocele repair and repair of occipital encephalocele. This topic will be presented by Dr. Aliu Ladan from University Osman Danfodio University Hospital, Sokoto. So the presentation will be 25 minutes for each one, and there will be room for question and answer. Will be at the end of both sessions. We will entertain questions from the audience. We also have an important faculty member here, who is Professor David Udo, he's a professor of neurosurgery from University of Benin Teaching Hospital, Benin. He's our father, a mentor, and a trainer. So he will be the one, the invited faculty. He will be the one to direct and give us fatherly advice on this topic. So I don't know, the first presenter, are you ready to start, Dr. Aliu Landan?
Yes, sir. Yes, I'm ready. I'm ready.
Yeah. Yeah. So the presentation will be for 25 minutes. So try and as much as possible to go straight to the point.
Okay, sir.
All right, please. You can go ahead. I'll mute myself now so you can take over. Thank you.
Okay, thank you very much, sir. Good evening, everyone. Thank you for the opportunity to talk. Today, I will be presenting on the anatomy and introduction to the relevant anatomy of myelomeningocele and occipital encephalocele. And the second speaker will discuss on the operative management. And the discussion will be based on the following outline. By way of introduction, myelomeningocele is the most common congenital central nervous system anomaly. Sorry.
Please, if you are not presenting, can you mute your mic, please?
Okay, thank you very much. By way of our introduction, the slide is not moving. Sorry, this slide is not moving. Sorry, the slide was not moving initially. By way of our introduction, myelomeningocele is the most common CNS congenital anomaly. Okay, and it's actually a disorder of our primary neurulations, which result from incomplete fusion of a neural fault. It is characterized by protrusion of meninges and spinal cord through the open vertebral arches. Despite the folic acid fortifications and health education, the incidence has been reported to be up to 3.4 per 100 live births in USA and 2.2 per 1,000 live births study done in the northwestern Nigeria. The myelomeningocele is traditionally treated postnatally via cyst decompression, isolation of the neural tube, tubular of the tube, closure of the dura, followed by closure of skin. However, this thing was done postnatally. However, in recent times, this thing can be offered via fetal surgery. The primary goal of our surgical management of myelomeningocele is to prevent future neurological deterioration and stop existing neurological decline. Most patients with myelomeningocele require lifelong care, with multidisciplinary team are involved, of which the neurosurgeons, the primary honors of the patient, followed by urologists, orthopedic surgeons, and pediatricians. By way of a historical perspective, before 1960, the survival rate for all forms of spinal bifida was 10% to 12%. In other words, more than 90% of patients with spinal bifida do not celebrate their first birthday. However, surgeons were typically postponing their treatment until they reach the age of 2, believing that only strongest of the patient will survive that long. And then also before the introduction of antibiotics in 1940 by Alexandra Fleming, most of the infants with myelomeningocele succumb to meningitis. And then also patients with myelomeningocele come down with other abnormalities like hydrocephalus, which will further worsen their survival. And then the advent of the shunt also, which revolutionized the treatment of myelomeningocele, as patients with myelomeningocele with hydrocephalus are treated with the surgery and subsequently have a ventriculoperitoneal shunt. And those that survived the meningitis because of the advent of antibiotics, and then the shunt that they had, the patient that had hydrocephalus that had shunt, then they now come down with a renal complication, which was the commonest complications seen in patients after treating the myelomeningocele surgically. And then other procedures were actually developed, those of urinary diversions and artificial buoy sphincters, all of which improve the survival of this patient. So for us to understand the myelomeningocele, we need to revise the embryology of the formation of a neural central nervous system, and subsequent failures that occurred in the production of the central nervous system that lead to spinal dystrophism. The neural tube is the primordium of the entire central nervous systems and forms by the process called neurulation. And then neurulation is defined as embryonic process that leads to the ultimate development of the neural tube. There are actually two distinct phases of neurulations. We have the primary neurulation, which find between the 3rd and the 4th week of gestation, and which lead to the formation of neural tube from the cranium to the upper sacral level. And then the secondary neurulation, which span between the 5th and 6th week, which complete the distal sacral and coccygeal region. The neural ectoderm, otherwise neural ectoderm, which overlies the notochord, by the process of signaling from the notochord, which induce the condensations and thickening of the ectoderm to form the neural ectoderm, and subsequently the adjacent mesoderm from the neural tube. Longitudinal central depressions called the neural group develops along the neural plate, as which the edges of the plate heap up to form the neural tube. The closure of the cranial neuroforce occurs at 25th day of gestation, and other literature they report 24th day, and closure of that of cranial caudal neuroforce occur at the 27th day, while in other literature reports 28 days. And depending on the point of interruption of neural tube formation, the neural tube may affect the brain, in which it is called anencephaly, and when it forms the spinal cord, is called spinal bifida, ranging from different forms of spinal bifida, ranging from occipital to cystica. The primary defect is the failure of the neural force to fuse in the midline to form the neural tube. However, because of the failure of the formation of the neural tube, the subsequent multi-development of the mesoderm, which form the skeletal and muscular structures, will be defective. So this is a schematic diagram, depicting the embryological process. This is the yellow central portion, depicts the ectoderm, which taken to form the neural ectoderm. This one is the group and subsequently the folding. And then this one complete formation of the neural tube. And this overlying the mesoderm, which form the skeletal and the muscular component that covers the spinal cord. This is another sketch showing how the myelomeningocele is with the blue showing the cerebrospinal fluid, the neural tissues, and then the meninges covering the neural tissues. And this is one of the patients who operated recently with a thoracolumbar myelomeningocele. So epidemiologically wise, the myelomeningocele is the most common major birth defect with the overall prevalence between 4.4 to 4.6 per 10,000 live births. Internationally, the incidence of myelomeningocele varies widely from country to country and from one region to another, as we will see in the subsequent discussions. Racial and ethnicity-specific prevalence established that myelomeningocele is found mostly in the Hispanic women, which has the highest overall rate, followed by whites, blacks, and Asians. And the myelomeningocele are observed to have a slight overall female preponderance. However, in our studies conducted by Nasiru Jinjiri et al. In this our facility, find out that in our center, there's a slight male preponderance with male to female ratio of 1.3 to 1. And then the various geographical locations in terms of the region of the vertebral column. The myelomeningocele occur in the region of 5% in cases of cervical, and then thoracic 10%, and then the rest in the lumbosacral regions, which is in concomitant with our studies done in this facility by Nasiru Jinjiri et al., which shows thoracic to be 9%, cervical 3%, lumbosacral 88%. The etiology, the exact etiology of the myelomeningocele is not known. However, many genetic, nutritional, and environmental factors have been implicated. The notable ones are the deficiency of some certain vitamins and microelements, deficiency of vitamin B12, by vitamin B9, that's folic acid, vitamin B12, zinc. And there's also increase in prevalence in patient and maternal that have controlled diabetes mellitus, also patient maternal obesity, and then the pregnant woman using some certain anti-seizure medication like the phenytoin, carbamazepine, and bifolic acid. So that possible environmental factors are also been implicated, as I mentioned earlier, that we're seeing mostly in the Hispanic woman, and then also some seasons has been noted the incidence to be increased in the dry or heat season in our setting and in the summer in the Western world. While patients with low socioeconomic status have been attributed advanced maternal age, maternal alcohol abuse, or mother exposed the maternal hypothermia during the first trimester of pregnancy. There's also slight female preponderance, as I mentioned earlier, and also the genetic basis, because there increased frequency, increased prevalence in offspring born to consanguineous parent when the marriages are consanguineous. And there's also increased rate in some patients with some abnormal chromosomal abnormalities like trisomy 13, 18, and 21. Myelomeningocele is also associated with other congenital anomalies like the clubfoot, which 60% of patients they have a clubfoot. Some may be associated with a KRD2 in 80 to 90%, hydrocephalus in up to 80%, and others neurogenic bladder and musculoskeletal defect. Then we'll go to the occipital encephalocele. Encephalocele simply means, simply defined as extracranial herniation of cerebral tissue through a defect in the cranial undura. The third most common craniospinal dystrophism, and it's spanned from the spectrum of anencephaly to spinal bifida occulta. This is a schematic diagram, showing the occipital encephalocele, showing the herniated brain with the dura and the cerebrospinal fluid. And this is a lab patient we manage in this facility with a very huge occipital encephalocele, close to the size of the head of the patient. So several theories have been proposed to explain this congenital anomaly. The one by Geoffrey, which was coined in 1827, which is a French neurologist who described the encephalocele as a hernia du cerveau, which is literal English meaning is a herniation of the brain. According to this theory, there's adhesion between the neural tube and germinal membrane, which prevent mesodermal differentiation and hence a defect in the calvarium through which the brain herniates. And then other theory is proposed by the von Recklinghausen, which says neural tube, which taught that the encephalocele is a neural tube defect with failure of closure of cranial neopause. But these lesions are actually covered by intact skin, unlike what we see in the myelomeningocele. Hence, they were believed to occur after renovation, and they were termed as post-renovation disorder. Another belief is that the neural tube closure, there's a disproportionate increase in the brain size compared to the size of the cranial development. Hence, the cranial cavity will not be able to contain all of the brain, so some of it will stay outside the cranial cavity. And then other theories by Marin Pradilla, which suggests that the axial mesoderm is mostly insufficient. And we know the mesoderm is one responsible for the formation of the cranial bud, the skin, cranial bud, and the muscles that covers the cranium. And then the other theory is that by Corbin et al., which suggests that there is incomplete disjunction of the cranial neuroectoderm from the surface ectoderm that retard the complete closure of the cranial cavity. Hence, because of the defect, the brain cavity, the cranial, the brain will now herniate via the defect in the cranial, in the cranium. The epidemiology of the encephalocele, the overall incidence of encephalocele is said to be 0.3 to 3 per 100 lab beds. They are 10 times less common than myelomeningocele. And the prevalence of encephalocele in the United States and Europe is said to range from 0.3 to 4.3 per 100 lab beds. And then in northwestern Nigeria, study conducted in our facility by Nandi and Swati in 2006 reported one case of encephalocele by 163 lab beds, which gives prevalence of 0.098 as compared to that of neural tube defect of 4.6%. Hospital encephaloceles are common in the United States, England, and Germany, whereas frontoethymoid encephaloceles are common in Southeast Asia. The encephalocele generally affects both males and females, as in contrast to the myelomeningocele, in which we see there's the overall female preponderance as against our study, which we conducted here, there's slight male preponderance. The etiology of encephalocele is certainly multifactorial. Environmental and genetic factors are considered to be involved. The early studies suggested that environmental factors rather than genetic. And then also observe patients, the hamsters, pregnant hamsters, they were exposed to arsenic, come down with a high incidence of encephalocele, but this has not been established in humans. The role of folic acid supplementation to prevent neural tube defects has been well documented. However, folic acid fortification in pregnant women is said to have been observed to decrease the prevalence of encephalocele. However, there is no direct causal relationship between the folic acid factor and encephalocele, as has been proven in patients with meningocele. High socioeconomic status, advanced paternal age associated with high incidence of occipital encephalocele, maternal hypothermia in first trimester, viral infection, hypervitaminosis, notably vitaminosis A and D, are also believed to be associated with encephalocele. Encephalocele can also be acquired following trauma, surgery, or some neoplasm, infections of the cranium. And this can be explained by the various classifications of the encephalocele. The encephalocele can be primary, in which the patient is born with it, and secondary, when it results from the either trauma, surgery, or neoplasms. And the also encephalosis can be classified based on the content of the swelling. If the swelling contains only the meninges without the neural, without the brain tissues called meningocele, when it contains the meninges and the brain tissues called encephalomenincocele, when it contains the meninges, brain tissues, and the ventricles, is encephalocystocele. And then there's this classification by Sonwela and Sonwela, which classified the cranial encephalocele into various 5 classifications: occipital, cranial vault, frontoetmoidal, basal, and posterior fossa. And then the pathology of the content of the encephalocele. The herniated part of the brain is usually glioid and non-viable brain tissues, and can therefore be excised completely during the surgery. And this was a study conducted in 1998 in Pakistan, in which 28 patients that had excision and repair of encephalocele. The excised encephalocele was just subjected to histology, and they found out all of them have glials and non-viable brain tissues. However, encephalocele can have variable, unpredictable content. So after the excision, after the exposure of the cystic sac, it's better to examine to see whether the brain is viable, and at times they may contain some dural sinuses in them. And then the various content of the encephalocele, they found out that 37% of the hospital encephalocele contain cerebral brain tissues, 21 contain both cerebral and cerebellar tissues, 5% contain only cerebellar tissues, and 37% contain nodules of glial and other dysplastic neural tissues. And a patient with a large encephalocele tend to have microcephaly due to reduction in the cranial volume and craniofacial disproportion in favor of the face, as against what is seen in patients with hydrocephalus, who they have craniofacial disproportion in favor of the cranium. The skin covering the encephalocele is usually normal and has no primary defect, but it may be thin, glistening, and focally deficient at times, maybe because of the way patient is being placed. Repeated pressure on that thing can make the area, the certain part of the skin thin and focally deficient. And then the connection between the nervous tissues within the sac and the underlying brain tend to be very narrow, which can be sacrificed during surgery, and then hemostasis will be skewed. And intracranial vessels may also enter the loops of the sac, in which it is called M. passer vessels. Encephalosis also has related to other malformations, which is seen in almost 36 to 40% of patients. The most commonly associated cranial malformations include hydrocephalus, Kerry malformations, corpus callosum abnormalities, microcephaly, and cerebral dysgenesis. And then commonly associated extracranial abnormalities include facial dysmorphism, cleft lip and palate, hypertelorism. And there are various syndromes that are noted to coexist with the encephalocele. We have the Michael-Gruber syndrome, in which the encephalocele coexists with the polycystic kidney and then polydactyly. And the Knobloch syndrome, in which this syndrome patient will have encephalocele, myopia, and vitreoretinal degenerations. There are also syndromes like von Bosch-Chosboy syndrome, in which patient will have hydrocephalus, phecomelia, cleft palate, irregenital abnormalities, and other syndromes are Walker-Marburg syndromes, hydrocephalus now coexisting with agarria, retinal dysplasia, encephalocele, and corpus stem lissencephaly. And then other syndromes like frontonasal dysplasia, broad nasal tip, broad nasal root, hyperthyroidism, and true cranial bifida. So we'll stop here, and then this other part of the presentation taken there.
Thank you. Good evening, everyone. I will continue from where the first presenter stopped. Pre-operative evaluation of patients with encephalocele and myelomeningocele include adequate history takings. This includes history of associated congenital anomalies, especially the cardiac and renal abnormalities, because this one may interfere with the interventions surgeons want to offer. Interventions like traditional scarce incisions that has been made prior to patients presenting to the hospital. History that may suggest sepsis, fever, vomiting, neck stiffness is important to get this history in order to optimize the patients prior to the surgery. Examination, patient have to be examined for fallow. If it's anemic, have to be optimized. the site size of the both encephalocele and myelomeningocele is necessary, and the nature of the lion skin, whether it's a ulcerated or not. The investigations preoperatively is good to do a craniocervical MRI in patients with occipital encephalocele. This will aid in determining the site of the defect, the content of the defect, as well as the associated vascular anomaly, especially the venous sinuses. This is a sagittal craniocervical MRI showing an occipital defect with herniations of the cerebellum and the first of the cerebellum on the right side of the image. Where on the left side is a MRI venography showing relationship of this swelling with venous sinuses, especially side of the tocula. And this may aid in classifying the encephalocele into either supra or infratoccular type. Other investigation necessary, including full blood count and differentials. This help in determining if the patient is evidence of sepsis, anemia, electrolyuria, and creatinine. Check the renal status prior to taking patients for surgery, and it's good to do a group and cross-match blood, which is necessary for the procedure. Prenatal diagnosis, serum, maternal serum, alpha-fetoprotein, and acetylcholinesterase can be elevated in patients with neural tube defects. Following the investigations, patients need to be optimized. If there is anemia, need to be corrected. Infections have to be treated. If there is evidence of dehydration, patients have to be rehydrated. A well-informed consent need to be obtained from the caregivers. And this include the concern about the clinical diagnosis, the extent of the pathology, the interventions we are trying to offer to the patient, as well as the possible outcomes, because it's very important to inform the patients, yes, the possible motor and sphincteric outcomes, both urinary and the fecal. This sagittal T1, T2 sagittal and axial lumbosacral MRI showing a posterior spinous defect with herniations of the thecal sac, as well as the containing cerebrospinal fluid and the meninges. L5 and it's slow line as a sign. Anesthesias for these anomalies tracheal tube intubations. Position is front in patients undergoing myelomeningocele surgery, as well as the occipital encephalocele. However, for those patients with giant occipital encephalocele, a lateral position can be done. This is an intraoperative image showing a child with an occipital encephalocele position prone. And here it's important to know that the head rings have to be put over a horseshoe, as well as the eye have to be padded. Then a chest roll as well as the pelvic roll have to be placed so that to allow the abdomen to be free. The incision for occipital encephalocele is mainly elliptical incision. Okay, this is an intraoperative image of a giant occipital encephalocele after dressing. So the incision will be done elliptically. After incisions, a blown along with the sharp dissection will be done till the bony defect is reached on the occipital bone. After a bony defect is being reached, then incision will be made at the apex of the cystic swelling. This will allow the egress of the CSF, as well as allow the surgeons to visualize the contents of the encephalocele. As the first presenter earlier mentioned, most of the content of occipital encephalocele is mainly gliotic tissues. So after which the tissue will be excised using a bipolar diatomy. Cares need to be taken here in order not to injure the dura, because this may subsequently lead to CSF leak. Following excisions of the plastic neural tissues, a water-tight tension-free dura closure will be done using either Frohlich 4O or Becquerel 4O. After which the skin will be trimmed and subsequently closed using either simple interrupted suturing technique. For the myelomeningocele, the position is sprung as in occipital encephalocele with the pelvic and the shoulders for head need to be placed on the horseshoe, which eye finding. Then the incision for the myelomeningocele is important to note. The component of the myelomeningocele appears as the most central area of the placard, followed by a region of zona epitheliosa as well as the side of the normal skin. So incision will be made between the junction of the normal skin as well as the zona epitheliosa. After making the incisions, then a blunt dissection will be done and till the edges of the facial defect has been reached, following which a durotomy will be done as shown in this image, whereby they allow the egresses of the CSF as well as the both ventral courses of the narrow will be visualized. It's important to note that as someone often the dura here is to reduce the risk of subsequent subarachnoid hemorrhage. This and here after the opening of the dura, the next step now is to tubularize the placard. Here the pair arachnoid matter as shown in this image will be tubularized. After tubularizations of the mobilize the dura, this is done by using it will dissect it down to the side of the bony defect. And it's important to know that during these dissections, care have to be taken in order not to injure the dura below, which may consequently lead to CSF leak. After mobilization of the dura, is the next step is to do a tension-free watertight duroplasty using a continuous suturing technique. However, some people advocate a double layer suturing technique in which after the first layer of continuous suturing, the second interrupted layer has to be done. There is no statistical significant difference between either single layer or double layer suturing and duroplasty in myelomeningocele surgeries. In some cases whereby after the duroplasty, the next thing is to suture the thoracolumbar fascia, which is the third layer to be sutured, then subcutaneous tissue, as then finally the skin. The skin can be either closed using interrupted suturing techniques. However, in some instances where there are giant myelomeningocele, there is need for intervention by plastic surgeries to provide a soft tissue cover, and usually the type of soft tissue cover is a Z-plasty. Following after the surgery, and the wound will be cleaned and patients will be dressed off. The position post-operatively patient need to be position prone. Caregivers have to counsel on the need for them to avoid allowing the fecal matter to contaminate the wound. Patient will be placed on post-operative antibiotics, analgesia, as well as regular monitoring. Monitoring here is to look for the features that may suggest a hydrocephalus, which may subsequently develop as a complications of myelomeningocele surgery. In a review on the a randomized control trial done to either differentiate between the prenatal and postnatal repair of myelomeningocele, and the primary outcomes they measures here is the fetal and maternal mortality post-operatively, then development of hydrocephalus within 12 months after the surgery, then neurological scores, including the motor outcomes. So it shows that from this mom steroid, it showed that most of these the parameters measures, they are more in favor of prenatal repair of myelomeningocele compared to the postnatal repair of myelomeningocele. Complications of these procedures include the cerebrospinal fluid leak. This usually occurs intraoperatively due to inadvertent injury to the dura or during either tension, duroplasty, or not a watertight suturing technique. And it can be avoided by meticulous dissection during mobilization of the dura during a tension-free watertight duroplasty. Infections include both surgical site infections and deep infections, including meningitis, can occur. Pseudomeningocele is another complication that can be seen in patients that had myelomeningocele or occipital encephalocele repair, and it is usually being prevented by ensuring that CSF leak is being avoided. First, excision and repair hydrocephalus is another complications that can be seen in patients that had both occipital encephalocele repair as well as the myelomeningocele repair. And other complications include the theta cord, which can either be as a complication of the intervention or as a primary component of the pathology. In conclusion, the surgical management of occipital encephalocele and myelomeningocele require a multidisciplinary approach involving neurosurgeons, pediatricians, rehabilitation specialists. The goals of surgery are to prevent further neurological deterioration, reduce risks of infection and hydrocephalus, and improve patients' quality of life. This is our reference. Thank you for listening.
Yes, thank you so much, our team from Osman Danfodio University. It was a wonderful presentation. You kept to time. Thank you, Dr. Aliu and Dr. Haliru Landan, for this presentation. They've gone through the common pathologies of CNS anomalies that we find in our environment. And they focused on myelomeningocele and encephalocele. They told us about the embryology, the pathoanatomy, and also the steps in surgical repair. So well done for the presentation. I think there are some important highlights in the presentation, which I just want to bring to the fore. Interestingly, the effect of low socioeconomic status, is known that these pathologies are commoner in Africa because of poverty and other associated factors. And they also highlighted the embryo anatomy. While myelomeningocele is primarily due to failure of primary neurulation, where the caudal neuropore either fails to close or ruptures after closure. And they also mentioned that occipital encephalocele or general encephalocele are post-neurulation disorders, and has to do with problem with migration of the parexial mesoderm. An interesting topic, and also the major aim of repair, which they talked about, was first is you must have a watertight, tension-free repair, and that is the hallmark of the repair. And they also mentioned issues with hydrocephalus and myelomeningocele and encephalocele. So I will open up to the house now for questions, contributions. Please, if you have a comment or question you can either raise your hand up and recognize, you just introduce yourself, tell us your center, your country where you practice, and ask your question. If you prefer to, you can post the question on the chat group and I will read it out in due course. So the house is open for questions and contributions. Before we go ahead, I want to recognize some very senior members of the faculty among us. I want to recognize the NANS Secretary General, Professor Tayo Ojo, is in our midst here. And also I want to recognize Dr. Opara. She's one of the senior, one of the ESCOs of, former ESCOs of YNNF, and current one of the ESCOs of the Young African Neurosurgery Forum. I want to welcome them to the discussion. And also, I also want to welcome our international members present, Professor Dr. Kabulo, DM Kabulo from Congo. So anybody with questions, please, you can please make your comments. The floor is open. Thank you.
With your kind permission, Dr. Campbell, Mr. Moderator, you
Yes.
mentioned Dr. Abulo, just permit mention that he's the chairman of the Young African Neurosurgeon Forum. We're privileged to have him here.
Yes.
Also present here is Dr. James Malopun. We recognize your presence, so we're really glad that thank you so much.
Thank you so much. So, question, comments, the floor is open, please. There's a comment on the group. The person was commenting on, he had a complaint that the intraoperative pictures are not real time. I don't know, the presenters from Sokoto, did you put up real-time images, for us to be able to follow the surgical steps during your discussion? Hello, Dr. Aliu.
Yes, sir. Sir, we do not put real-time images to improve on the subsequent presentations.
All right, that's fine. Okay. Any other question? If not, I may have to invite our faculty. Any other question from the participants present, please? The floor is open. You can unmute your mic and make your comment or ask your questions, please. Okay. All right. I don't know whether Professor David Udo is in the house. I want to introduce Professor David Udo. He's one of our mentors and our trainers in the South region. He's the head of neurosurgery in University of Benin Teaching Hospital, and he's one of the pioneer neurosurgeons in the South region and in University of Benin. He's our trainer, our father, our mentor. I want to welcome him to this webinar. Professor Udo, I don't know whether you can hear me.
I can hear you. I can hear you.
Yes, Prof. Thank you so much. We are privileged to have you in our midst, sir.
Thank you so.
Yes, sir. Please, Prof.
Thank you so much for inviting me.
Yes, sir. So if you can give us some highlights and some important things that we are supposed to take home with in these very common surgical pathologies from your wealth of experience. We really appreciate that, sir. Thank you, sir.
Okay, thank you so much. I want to welcome everybody on this webinar right now, our very senior international and fellows, as well as senior members of NANS who are present here. As you have already been introduced by Dr. Campbell, I want to say welcome to all of you. Thank you for joining this webinar this evening. And I also want to welcome, I want to thank Dr. Dong Guga, who also had to put some of these things together. Thank you so much, Dr. Dong Guga, and thank you for the efforts it took you to ensure that I'll be sitting here today. I wasn't even sure of it. Then I want to say a huge thank you to the two presenters, Drs. Ladan and Ladan. And in the time at their disposal, I think they have done immensely, okay, as regards the task in front of them to this webinar this evening. Thank you, Dr. Ladan, and thank you, Dr. Ladan. I just want to note a few things. I was expecting a number of people who are present here to make some comments on the presentation as well as give us some insight and corrections, but I didn't hear many. Firstly, the central nervous system, when you consider the embryology of central nervous system, is as complex as any other organ in the body. I once sat with Professor Shokunbi, discussing with a group of some other people, and he discussed with passion how he dropped his desire for cardiac surgery to suddenly follow another passion, which is neurosurgery, because of the organization of the central nervous system. And believe me, it's the neuroembryology, especially of neural tube defects, that actually shows most aptly the organization of the central nervous system, especially in the area of the embryology. And when Dr. Ladan was presenting the embryology, he spoke about quite a number of things, but he was so brief on neuroembryology itself, which was meant to be the focus of his discussion. The introduction was apt, where he spoke about relation, surgery, postnatal and prenatal, lifelong care, a multidisciplinary approach to management. He also looked at historical perspectives, but somehow the embryology itself was quite short. If we remember that there are 23 stages, in human embryology, which refer to the first 60 days after ovulation. And of all these 23 stages, stage 8, which refers to the 18th day embryo, stages 8 all through to stage 13, which refers to the 28th day embryo, are very important in our topic today. And I didn't really hear much of that. I heard quite a lot about epidemiology and all that. Thank you, Dr. Ladan. Anyway, you have to look at the neuroembryology again, which was your main discussion in the webinar. And you have to look at the stages of development and the days concerned as it concerned your part of the presentation today, which was neuroembryology. He touched something very important, epidemiology, in his discussion. And I listened to the epidemiology with interest. And in Benin here, about 53% of our patients who undergo pediatric neurosurgery are operated for congenital anomalies. And spina bifida, among them, those with spina bifida will mostly present, within the first 6 months. Within the first 6 months, sorry, I'm going into detail about this because I wanted to hear that. Within the first 6 months, about 70% of them are likely to have presented to most units. And by the age of 15 years, 95% of them would have presented. And I think this is the same, as the figures they have from most other centers in this country, like the 2012 study by Professor Bankole, and the study by Odeku in 1963, and Benitier from Jos. They say 76% of all, in Benin, 17% of all operative surgeries in neurosurgery will be pediatric neurosurgery, and 53% of this 17% will be on congenital anomalies, like I've said earlier. So you spoke about embryology, but you spoke about epidemiology, but not in detail. Also the embryology, you did not speak in detail about the embryology. Then your illustrations, I thought it would have been good to show us more illustration on the neuroembryology of neural tube defects. Okay, we would have loved to see the differences in the various types, you know, of encephalocele and the various types of, okay, maybe we are just talking about myelomeningocele, but would have loved you to draw some differences between the various types. But that is about all for the embryology part of this discussion. And then when I listened to the operative part of the discussion, Dr. Ladan also was supposed to tell us about the operative steps. He was too conscious of the time. I think Dr. Ladan was quite conscious of the time, and I must credit them for doing everything within the time allotted them. The operative details, especially on encephalocele, occipital encephalocele. You could have given us more on the operative detail. Okay, I had your incision. I had carrying it as far as the bone, but I didn't really hear how you harvest your dura, you know, how you separate the dura from all the other soft tissues covering the encephalocele. And anyway, your operative detail was not, you didn't give us enough detail on your operations. Then on the myelomeningocele, you went a little further on myelomeningocele. But by and large, I want to say that it was a brilliant presentation. And I just want to say that there probably would have been room to discuss a few more things, especially in the areas I've highlighted: neuroembryology, epidemiology, and statistics, especially as it concerns various regions of the country. Then the stages of embryology that actually concern our discussion today, stages 8 to 13. That is the 18-day embryo as far as the 28-day embryo. Then finally, operative detail. Thank you very much. If there's other insights, oh yes, I had some mention of fetal surgery. It was a little brief, but it's okay that he mentioned it and he gave us maybe some insight in the fetal surgery. Is that things to be, you did not mention if the fetal surgery will be performed via hysterectomy or just a simple puncture or endoscopy. You needed to have told us that. And you did not mention the reasons that favor fetal surgery and the reasons that might account as a disfavor to fetal surgery. What time is appropriate for fetal surgery if it is going to be performed? Okay, and there are evidences to show that there will be toxic injury or mechanical injury to the exposed neural tissue in utero. Then what about the effects of fetal surgery on hydrocephalus if the child has associated hydrocephalus in utero? Then I want to say that does the skill we have available to us on prenatal ultrasound, does it really suffice to tell us about all the associated abnormalities in this fetal surgery before we carry out fetal surgery, in this fetus before we carry out fetal surgery, knowing that in some of them there may be cardiac, urogenital, intra-abdominal anomalies as well. You did not mention if we give those considerations when we are considering to go ahead and have fetal surgery so as to prevent the progression of the of the of the neurological deficits in myelomeningocele in utero. I will stop here for now and hand over to the moderator. If there are other things I need to mention before we go, I will mention them. Thank you very much.
Yeah, thank you so much, Prof, for that very extensive talk on the topic. We really appreciate having you in our midst, and it was quite great interaction with you, sir. We are grateful. I also want to, there was also some very senior members of the faculty that are within our midst. I want to recognize Professor Chiazonia, is also here. Dr. Kabulo, I don't know whether he's still around. I wanted us to give us a slide talk of their experience in Congo. I don't know whether he's still online. Dr. Kabulo is the current chair of YNF. Okay, I can't see him on the group. Okay, I also have another senior member of faculty here, Dr. James Bagologun from University College Hospital, Ibadan. Chief, I don't know whether I can give us one or two insights on the topic myelomeningocele and encephalocele management. Dr. James Balogun, sir.
Sorry, I pretty joined late. I didn't even get any of the lectures. It was just the comments that I joined in to listen to. So I will just toe in with what Professor Udo has, the things he has mentioned, and I hope that we can continue to learn in that regard. Thank you.
Thank you so much, sir. I appreciate it. Dr. Ojo is also in our midst. Is the current Secretary General of NANS. Dr. Ojo, Tai Ojo, if you can unmute and just a word of advice for the young neurosurgeon.
Yeah, apologies. I'm only listening in. I'm not able to make comment where I am right now.
Okay, sir.
Thank you.
Thank you very much, sir. Okay. Any other comments from the participants? Please, you can unmute yourself and let's give like 5 minutes for comment before we close the discussion. Any other comments from the participants? Our international participant present, please. You can unmute and introduce yourself. We really appreciate having you in the forum. Okay. All right. It has been a very wonderful evening, and we have discussed. Sorry, there was a mistake. Professor Ojo is the immediate past secretary. Sorry, it was a mistake from me. I apologize, sir. Yeah. So we've had a very nice evening where we discussed one of the commonest pathologies we see in our clinics, especially myelomeningocele and all the issues. Professor Udo, his wealth of experience has actually thrown a lot of light and highlighted, the critical areas that are important for the neurosurgeon and for the residents to pay attention. And I really appreciate you, sir, for the talk on your wealth of experience. We are grateful having you in our midst.
Thank you so much, Dr. Kimball.
Thank you, sir.
Thank you, sir.
Yes. So I want to hand over to the ESCOs of YNNF to if there's any announcements and for them to close the meeting.
He's still.
Dr. Jerry Ghana.
Stage 8.
All right. It looks like Dr. Guga is not online at the moment.
Okay.
Good evening, everyone. Dr. Para speaking. So we just want to thank the Sokoto team for giving us a very wonderful presentation. I want to appreciate our moderator for the day. Thank you so much, sir. You did an excellent job. And thank you to everyone who contributed in one way or the other. Please let's note that our YNNF webinars come up on a monthly basis, and very soon we will send out the topic for our next webinar. We want to appreciate everyone for joining in. Thank you so much and have a wonderful evening. Goodbye.